All right, so my name is Brian Earp. I'm from Yale University, and I'll jump right in and take us back to the year 2012, which was a very different world we lived in back in 2012. It's also the year the American Academy of Pediatrics came out with their updated policy statement. Now, we know that their main conclusion was that the benefits of newborn male circumcision outweigh the risks, and they further concluded a sort of policy conclusion here that the benefits justify access to families who choose it. I want to draw attention to an interesting rhetorical maneuver here. They say evaluation of current evidence indicates, and I call this the data speak for themselves rhetorical maneuver. The data never do speak for themselves. There's always an active interpretation, subjective judgments that go into analyses of the medical literature, and I'll focus on some of those in a moment. The other issue here is the policy conclusion. You might think that even if you had an objective account of the relevant benefits and risks, there would be various sociopolitical and ethical steps that would need to be filled in before you could arrive at any particular policy recommendation. So here I call this the data entail policy X rhetorical maneuver. I'll come back to these ideas in just a moment, and you'll see why they're relevant. About 6 months later, there was this critique published in the same journal, Pediatrics, by these senior European physicians. They drew a very different conclusion looking at the same medical literature. The highlight here is the other claimed health benefits, apart from urinary tract infections, are questionable, weak, and likely to have little public health relevance. So what's going on here? When you have two groups of doctors, seemingly of comparable qualification, looking at ostensibly the same medical literature and yet drawing opposite conclusions, you have to ask how you might explain that difference. And when you see polarization like this within the medical literature and in other areas of science, you often find that underlying these different judgments are potentially different values, different subjective judgments of one kind or another. Cultural norms may be playing a role in how the doctors interpret the medical literature. There's even the possibility of cultural bias, which I won't have time to talk about today, but a colleague and I have just come out with a paper discussing the role of cultural bias in medical judgments, which is an interesting and difficult issue. Now, I'm not going to dwell on each of these reasons for international skepticism about the American Academy of Pediatrics statement. I'll leave them here for the record, but I'll focus on just the last two. There was no description of the anatomy or functions of the foreskin, which is the part of the penis that's removed by circumcision. In essence, the AAP task force said circumcision is a surgery that removes the foreskin, whatever that is, and here are some benefits that follow from this surgery. The difficulty with this is that if you assign any value whatsoever to the tissue itself, then its sheer loss should be counted as a harm or as a cost to the surgery. And so part of the room for subjective judgments comes with implicit valuations of the healthy functional tissue that's removed. If you implicitly assign it a value of 0, then it's seen as having no cost by removing it except for additional surgical complications, which will become relevant. In response to international pushback in a later publication, the task force members said, well, the benefits were felt to outweigh the risks. And the reason why they were left making this more subjective sounding statement is because, of course, they used no procedure by which you could measure or weigh or balance benefits and risks. Is one benefit worth two risks? What's the magnitude of them? How would you possibly make such a comparison? And so, of course, it's going to come down to one's subjective evaluations. There is no metric that can be used, as I will argue, to objectively measure or balance these issues. So this is a much softer claim than evaluation of the evidence indicates, but it's certainly a more accurate way of describing how this conclusion must have been reached. So how do we assign weights or values to benefits and risks, and what would it mean for the foreskin to have some sort of inherent value? I'll discuss that next. This is an editorial by Andrew Friedman, Dr. Andrew Friedman, who was one of the key task force members of the 8-member task force. He published this last year, and this is an editorial in Pediatrics in which he concedes at least some of the criticisms that had been raised by the international critics. He says, well, there were difficulties with our approach. It included the lack of a universally accepted metric to accurately measure or balance the risks and benefits, and there was insufficient information about the actual incidence and burden of non-acute complications. Why might there be a lack of a universally accepted metric? Well, the first thing you have to do is figure out what counts as a benefit or risk. There's going to be room for disagreement here between people with different attitudes. Let's take the example of a decrease in penile sensitivity. Now, at minimum, any sensation or sensitivity that would have been experienced in the excised tissue is by definition precluded or made impossible by circumcision. But in addition, in some men, there's further desensitization of the penile glands, or the head of the penis. The reason for this is that the glans is an internal organ. It's covered and protected by the foreskin, just as the clitoral glands is protected in women by the clitoral hood. And when you remove this protection, the glans becomes an external organ. And now it rubs against clothing and other elements year after year, and in some men this can increase the risk of desensitization. Now, is this a benefit or a risk? Well, some people say that seems like a harm, sexual dysfunction of some kind. Lack of sensation doesn't sound like a sort of thing that I would like to have happen to me. Whereas others might say, well, no, it's an aid against premature ejaculation. I don't want to be too sensitive, so one and the same outcome could be construed by someone else as being a benefit. And indeed, those who defend or promote circumcision often will make a generalized claim that it can work as an aid against premature ejaculation. Now, as I'll discuss, these generalized claims don't work. Everyone's sexual experience is, of course, unique, and what happens for one person may not apply to someone else, so we should be cautious about making general statements based on averages or similar data. Well, it might be a benefit and risk over time. Maybe as you're a younger person, you appreciate a relative lack of sensitivity, and you say it's a benefit. And then as you grow older, you find that you could use all the sensitivity you can get, and maybe now you struggle with erectile dysfunction. So you already see the complication in trying to come up with an objective statement about whether one and the same physical outcome should be considered a benefit or a harm. And as I mentioned, there are individual differences. Each person's genital and other anatomy is unique, from the number and distribution of nerve endings to the sensitivity in different parts of tissue. And when you're looking at an infant, you have no idea what their sensory profile will be later in life relevant to their sexual experience. So by authorizing a surgery that early on in life, before they've had any experience with the erogenous tissue, you don't know whether they might need all the sensitivity they can get. So there's a further risk that's introduced. Well, now let's take the example of the removal of the foreskin itself. And here I'm going to talk about symbolic or social meanings that might be attributed to this outcome. And here we can assume that there are no surgical complications. So the person performing the operation might say this went off flawlessly. Well, what's the meaning or symbolic value of this outcome? If you're a practicing Jew, you might consider it a sign of the covenant with the deity, which is an extremely beneficial association. Even if you're not particularly religiously observant, among Jews and Muslims generally, circumcision is seen as a strong symbol of cultural affiliation, which again could be seen as a social benefit to the procedure. On the other side of the coin, if you disidentify with the religious or cultural group in which you've been raised, you might have a very different attitude, again, toward one and the same outcome. Now you might say, well, I feel marked with a symbol of my parents' religious beliefs. That's a very different sort of outcome. A friend of mine was raised in a Jewish community and now identifies as an atheist, and so he has very strong negative attitudes toward the religious commitments of his parents. And he tells me that every time he goes to the bathroom or takes a shower or has a sexual encounter, he's reminded in his mind of having been engraved, in his view, on the most intimate part of his body with a symbol of religious beliefs that he rejects and that in fact he has very negative attitudes toward. So this is very personally distressing for him. The point I want to highlight here is that the outcome, the loss of the foreskin, is the same across these cases, but one's attitudes toward that may differ tremendously, and so the harms that come about via psychological mechanisms are highly individually variant. Some people might view a circumcision as a cosmetic enhancement. This is particularly common in cultures where one has been socialized to see circumcision as the norm. But again, one and the same outcome might be seen by other people as a cosmetic diminishment, particularly if attention is drawn, for example, to the scar tissue that forms around the circumference of the penis. Some people might find it unsightly. Some men have no idea that that's associated with their circumcision or even that it's scar tissue. Well, let's say that we had a compendium of benefits and risks. Well, how much weight should we assign to each one of them? This is a further issue and a further problem, I would argue, with the American Academy of Pediatrics approach to this analysis. Let's take the example of a reduction in risk of urinary tract infections, which is the main benefit that's been associated with newborn or early childhood circumcision in particular. How much weight should we assign to this? Well, you can't answer that question until you take into consideration further elements of the decision-making process. So one here is that the absolute risk of getting a urinary tract infection is about 1%, regardless of your circumcision status early in life. It may be a little more than 1% if you're non-circumcised, a little under 1% if you are circumcised. These data are contentious, but even if you take them at face value, it would take more than 100 circumcisions to prevent a single urinary tract infection. You also need to take into consideration alternatives. That one and the same urinary tract infection could, of course, be treated with oral antibiotics, as urinary tract infections are treated in the case of girl children. Girls get urinary tract infections about 10 times more frequently than boys do after the first year of life. And in that case, the option of preventative surgery is not, of course, entertained. So when deciding about the magnitude or importance of this benefit, you have to take into consideration these other factors. Well, now let's look at something that looks a little bit more like a risk or a harm, the prospect of removing too much of the foreskin. The problem here is that there's no dotted line showing where the foreskin ends and the rest of the penis begins. In fact, there is no determinate location where that is. And so when you're looking at a very small or diminutive infant penis, you have to make a guess. You say, well, I guess we're going to cut here. The problem with this is that the penis increases by about 200% over the course of development. And so a cut that you thought maybe was in the right place, you might not know until 10 or 11 years later, when the organ has reached its full size, that unfortunately too much tissue is removed to accommodate a full erection, let's say. This can lead to painful erections, curvature of the penis, and other problems. The difficulty here is that these data are not recorded anywhere. Because there's a decade lag between the surgery and when anyone might notice that there's a problem, these are not recorded anywhere as a risk of the surgery except in random case reports. So we don't have any good data showing the actual frequency of this problem. A further issue is that if you were circumcised in early infancy, you have no alternative frame of reference. And so some people may experience such a problem and not even have it occur to them that it might be associated with a surgery that took place in infancy. You have the further issue of the magnitude to assign to this outcome. Well, that's just the felt badness of the outcome, which is going to differ from people, between people as well. And so you have to now multiply this unknown risk by the felt badness of the outcome to come up with anything even approximating a sensible account of the worth or the value of this harm. So as you see, if I want to balance benefits and harms, I can't even begin to do so unless I've taken into account these highly subjective evaluations regarding one's own body. In other words, a committee wouldn't be able to come up with a valuation that should apply to everyone. What weight should be assigned? It comes down to your values and preferences. There's not an objective answer. This is from the philosopher Scott Campbell. This is a philosophical account of harm. One of the components of risk is harm. This is the level of badness or loss associated with the occurrence of X, some action. Harm does not just include physical injury, but any sort of circumstance that P, a person, would prefer not to be the case. This entails that our attitudes and preferences partly determine risk because our attitudes and preferences determine what counts as a harm for us. So one consideration, as we've just seen, is that people disagree not only about the social or symbolic benefits and harms of circumcision, even within a given community, but even what counts as a physical injury is contested when it comes to circumcision. Is a loss of sensitivity a benefit or a harm? It depends on your perspective. So the implication of this is that we don't actually know if someone is harmed until we know their attitudes and preferences. And when you're looking at an infant or small child, the best you can do is make a guess about their future attitudes and preferences, but that's quite a gamble. Now, whose preferences are we talking about? If we go back to the editorial by Dr. Friedman, you'll see a number of references to parents and their preferences, but almost no mention whatsoever of the perspective of the child. So Friedman says, most circumcisions are done in the West due to religious and cultural tradition. Although parents may use the conflicting medical literature to buttress their own beliefs and desires, for the most part, parents choose what they want for a wide variety of non-medical reasons. There can be no doubt that religion, culture, aesthetic preference, familial identity, and personal experience all factor into their decision. Few parents, when really questioned, are doing it solely to lower the risk of urinary tract infections or ulcerative sexually transmitted infections. In a separate editorial or interview, Friedman stated, I circumcised my son myself on my parents' kitchen table on the 8th day of his life. But I did it for religious, not medical reasons. I did it because I had 3,000 years of ancestors looking over my shoulder. So again, we see reference to the ancestors looking over Dr. Friedman's shoulder, the parent's perspective, the adult's perspective, but no mention of the perspective of the person whose genitals are actually being altered in service of these considerations. I want to pause on the notion of aesthetic preference, listed here casually as one of a number of reasons why we might entertain performing a surgery on an infant's penis. If the infant were a girl and we were to say, I wonder what the future potential aesthetic preferences of her partner might be, or what my preferences as the parent might be, it's unclear what the referent is here, I think many people would recoil to think that entertaining, for example, a neonatal labiaplasty should be considered because some future sexual partners might have an aesthetic preference along those lines. And yet here, as I say, it's just folded in with a number of other reasons why we might reasonably consider performing a surgery on boys. In circumcision, what we have is a messy, immeasurable choice that we leave to parents to process and decide for themselves. It is inconceivable that there will ever be a study whose results are so overwhelming as to mandate or abolish circumcision for everyone, overriding all deeply held religious and cultural beliefs. I thought this was interesting. The statement suggests that regardless of what happens in terms of the development of the scientific literature, among some groups, religion and culture will always trump, almost by definition here. The problem is, again, whose beliefs are we talking about? If you want to consider religious or cultural motivations for genital cutting, it's relevant that social scientific research suggests that young people are increasingly leaving or disidentifying with the religion or cultural affiliations of their parents. In the United States, for example, while the US public in general is becoming less religious, the nation's youngest adults are by many measures much less religious than everyone else. The implication here is that when you change your religion or your cultural affiliation, or you move to a new location, or you gain new knowledge, your frames of reference or the basis for interpreting your own bodily state may also change. What happens then is that what you grew up originally considering just a normal state of your body, or maybe even an enhancement, which is a common view in the United States. A lot of circumcised men, as was mentioned, will say, well, I don't mind being this way. This is the way I prefer. This is normal. This is better. If you gain a different perspective or new information, you can then reconstrue what happened to you when you were an infant and consider one and the same bodily state now as a diminishment or even a mutilation. I want to pause on this word because in the Western discourse, the term mutilation is normally reserved for non-therapeutic female genital cutting procedures. The World Health Organization defines all such procedures as mutilation by fiat, regardless of the severity of the procedure and regardless of the views of the women who have actually undergone these procedures. What you find is that even in cultures where the cutting can be quite severe, the majority of women also regard their altered genital state as an enhancement or as normal. They'll say, my vulva is cleaner, it's more beautiful, it's easier to keep hygienic. So these sorts of attitudes will be common until Western activists move into some of these communities and say, don't you realize anything about the tissue that was removed or altered? Don't you realize that this practice isn't done in other cultures? And what you find then is that some of these women reconstrue what happened to them and say, I didn't realize those things, and now I do, in fact, feel mutilated. Here's an example that was told to a psychologist, Ronald Goldman. One of his patients said, the shock and surprise of my life came when I was in junior high school. I was in the showers after the gym. I wondered what was wrong with those penises that looked different from mine. I soon realized I had a part of me removed. I felt incomplete and very frustrated when I realized that I could never be like I was when I was born, intact. That frustration is with me to this day. Throughout life, I have regretted my circumcision, and daily I wish I were whole. Now, what's interesting here is there's no mention of complications of any kind. The suggestion isn't that he underwent a botched circumcision, as it's often described. This might very well have been a perfectly clinically adequate circumcision. Instead, he's had a different perspective, a change in mind rather than a change in body, where again he feels now harmed in virtue of a recognition that came about in this case in high school. There are many other such examples I could have given, but there's not enough time to go over them. But this is a common theme in the testimonial literature when you find documents of men who do indeed raise complaints. So in these cases, it's not that there was a surgical complication of some kind, but rather the sheer involuntary loss of healthy tissue that these men regard as having value or properties it's reasonable to consider as being valuable, and the loss of genital intactness is construed as being a harm in and of itself. If that's hard for you to imagine, you can again compare with the labia. Imagine a woman who had her labia minora removed in early childhood. It's not the case that she can't enjoy a sexual experience without labia, but she might reasonably say, I wonder what my sexual experience might have been like had I been able to retain the full complement of the nerve endings that I was born with. And indeed, I feel resentful that that option was taken from me, that this tissue was removed from my body before I could decline. So this raises the question of whether the loss of foreskin or labia or other healthy tissues, including in intersex cases, which is a surgery unfortunately we won't be able to talk about today, but there are a number of important parallels here, whether the loss of healthy genital tissue is a harm per se, even if there are no additional surgical complications. Well, in the case of the foreskin, in order to answer that, to give you some sense of why someone might even think of this tissue as valuable, you have to say, what's a foreskin? Well, it's an elastic sleeve of motile retractable tissue. It's quite a lot of tissue, at least enough to cover the surface area of a credit card. It protects the head of the penis, as I mentioned earlier, keeping the glands an internal organ, and therefore it's softer. The sensory properties of the glands are different when this protection is removed. And the foreskin itself is the most touch-sensitive portion of the male genital organ. On this last point, this is recent research from Jennifer Bossio and her colleagues, who did measurements on these locations on the penis, both circumcised and intact, She used a filament procedure whereby you press down a filament and it measures exactly how much force is required until the person says, yes, I can feel that. And so you have an objective measure of the sensory properties of the different portions of the penis. On these graphs, just so you know, a lower bar means more sensitive. And that's because it's a lower sensory threshold. That's why it's sort of counterintuitive. So as you see on, I guess, the left side of the image, the foreskin is more sensitive than any other part of the penis and the control site on the forearm when it comes to light touch. That's the top left corner. On the bottom left corner, this is feelings of warmth, detection of mild sensations of warmth. And on the right-hand side of the graph, you see that the foreskin is no more or less sensitive to painful experiences. So these are touch and heat pain experiences. In other words, the foreskin is acutely sensitive to mild and gentle sensations, which again is not typically thought of as part of the masculine sexual experience. But if you were to think, actually these mild, gentle sensations are something I might value, then you can see why the removal of this tissue would be counted as a harm. This research is consistent with an earlier study by Searles and colleagues who used a similar methodology, and they found that circumcision ablates or removes the most sensitive parts of the penis. I'll just show you a few pictures here. If you don't want to see them, you can look away. On the left-hand side, you see a non-circumcised or intact penis with the foreskin rolled back or retracted. You can see the coloring of the glands is a sort of softer, pinker color, reflecting different sensory properties. On the right-hand side is a circumcised penis where this protective covering has been removed, and as I say, the head of the penis is exposed to environmental factors over the course of many years, and so you have a sort of drier surface with different sensory properties. This is the motile behavior I was referring to. As you can see, there's contact between the underside of the foreskin and the glands that moves consistently back and forth during masturbation or sexual activities. And those particular sensations, as I say, are precluded by circumcision. Other sensations are, of course, possible, but if you consider those sensations valuable, you can see why the person might regard it as a harm. You can also see quite a lot of vasculature. This is about a third of the motile skin system of the penis that would be removed. And so this particular motile action is, again, not possible after circumcision. What remains is a sort of shaft only, rather than these intermobile parts. So is loss of foreskin a harm? Well, it depends on what you value or prefer. If those sensations are something you value or prefer, then their preclusion would be a harm. If you prefer to have unmodified genitalia, then a change from that state is a harm. If you prefer to have had a choice in the matter, then having that choice removed from you is a harm. As I say, values and preferences can change with new information or change of perspective. In the United States, some men will simply Google, what's a foreskin? They don't know anything about it. It's a taboo. It's not something that's really talked about. And all of a sudden, they learn there are these sensory properties they might have enjoyed experiencing. And suddenly, they, again, reconstrue what they had formerly seen as normal as being disadvantageous. You might travel to a non-circumcising country and realize that the norms or practices are different there. You might leave your parents' religion and reconsider the meanings, the symbolic meanings that you grew up with. The common refrain is, well, come on, men don't complain, so what's the big issue here? Well, a partial remedy to this is the website that Richard Dunker here has set up, called mendocomplain.com, where he's collected many testimonials, so you can see about that yourself. YouGov conducted a poll in 2015 of 1,000 American men, found about 10% wished that they had not been circumcised. My colleagues and I at Quinnipiac University, I'm based at Yale University, conducted a poll this year. We found 13.6%, and just so you know, these were very demographically diverse samples. They weren't sort of biased toward one population or the other. 13.6% indicated they wished they'd not been circumcised. Nevertheless, you might say, but still, most circumcised men don't regard themselves as harmed, so I don't see the problem. I'm happy to concede that there's a percentage asymmetry here. There are more men who are circumcised who do not regard themselves as harmed as who do. But there's also a remedy asymmetry. If you were not circumcised, but you wish that you had been, you have a choice available to you. You can undertake the surgery as an adult under conditions of informed consent. It might not be ideal for you, but you have an option. Whereas if you were circumcised in infancy and you greatly resent this, there's very little recourse. You can't undo the surgery once it's been done. And I think it's this asymmetry in remedy that's most ethically relevant rather than the mere asymmetry in percentage, which is in any event influenced by cultural norms which can change. Again, the same analysis applies to so-called circumcised women. This, by the way, is the term that would be used. The World Health Organization says mutilation, but women from these communities wouldn't use that language. Most of them do not feel harmed, including by extreme forms, including excision of the external clitoral glands or infibulation. And this is just almost impossible for people of a Western mindset to consider. How could that be so? It seems self-evident that the tissue that's removed or altered has value. So how might you explain this different judgment by those who have actually undergone the surgeries? Well, one common explanation is that they don't know what they're missing. If you've had a genital surgery before you've had a sexual experience, it should be obvious that you don't have a frame of reference about what the alternative would have been. And so it would be psychologically sensible for you to construe whatever your current state is, which you can't change, as being preferable. Otherwise, you would have to live with the consideration that it's not preferable. There are also often false beliefs, myths, and cultural conditioning which sustain this particular view of one's own body. So for example, in some groups, there's the view that the clitoris will grow to the size of a penis if it's not excised, that so-called uncircumcised girls are more promiscuous and therefore circumcision is required, and that uncircumcised vulva are dirty or hard to keep clean. These are very common views that, as you can imagine, if they are common enough in the culture, this would make it easy to fail to construe one's state as a harm. Well, a similar consideration applies to the foreskin in societies where male circumcision is common. False and stigmatizing beliefs as well as anatomical ignorance are widespread. This is a study of 90 American medical textbooks. So this is the means by which American doctors learn about the anatomy of the male genital organ. And upwards of 70% of the depictions of the male penis are depicted in a circumcised state. There's no asterisk saying, oh, by the way, some tissue would have to have been removed in order to make the penis appear this way. It's just a missing organ. There's no information about this tissue. So it's not surprising, again, that the American doctors would implicitly assign it a value of 0. So this author concludes American medical students are being misinformed about fundamental human anatomy. I was a little skeptical about this, I'll admit, and so I downloaded on my iPad the latest reproduction and urinary anatomy atlas from Visual Body. This is the latest and greatest electronic tool that medical students use to study for their medical exams, their anatomy exams. And furthermore, this is the one that's focused on reproductive anatomy, so I thought surely this is the one that will have the information about the foreskin. I zoomed in on the male model. These are screenshots from my actual iPad. I typed in foreskin to see what it had to say, and it said, your search returned 0 results. I thought, well, maybe I should use the medical term, so I changed it to prepuce. And it says, your search returned 0 results. So here it is, simply a missing organ. So you ask yourselves, how could the American Academy of Pediatrics fail to describe the anatomy and functions of this missing tissue? Did anyone on the panel themselves possess a foreskin? It's unlikely. Well, even in their medical textbooks, there's simply no information about the tissue, so this should not be surprising. Now, there is an entry for a prepuce, but it's over on the female model. This is the clitoral prepuce, which is the same tissue embryologically. It diverges. It says in the description, after going through the anatomy in details, it says this is analogous to the male foreskin. So the only mention of the male prepuce is over on the female model, and there's no description whatsoever of the anatomical properties of the tissue. So I wanted to test some of these ideas empirically. My colleagues and I, as I say, ran a study. We had 999, I don't know why we couldn't get 1,000 American men for a demographically diverse sample. And our hypothesis was that the greater proportion of false beliefs regarding the foreskin or circumcision, the more satisfied circumcised men would be with their status, for the reasons I've just described, and that the opposite would be true for non-circumcised men. Now, there's a problem in designing this study, which is that the literature is extremely polarized. There are people with agendas on either side, whether ethically or religiously, fighting each other by pumping studies into the pipeline, many of which are of extremely poor quality. And so coming up with a set of 10 items where there's an objectively correct answer was very difficult. But to do this, we recruited 2 experts, one who's very critical of circumcision and one who supports circumcision. And with them, we worked together to identify 10 items with respect to which there's one and only one correct answer as an objective matter of fact. I don't have time to go through each of them. I'll put them here for the record. But an example is, according to the American Academy of Pediatrics, there's good evidence that being circumcised is associated with lower incidence of urinary tract infections in boys under the age of 2. Well, that's objectively true. That's the claim of the American Academy of Pediatrics. We can go through the other items if you wish, maybe in a question period. So here's our procedure. Any wrong answers were summed into a false belief score. We had a 3-item satisfaction measure, essentially how satisfied are you with your circumcised state that had good internal reliability. Collected demographic data. I won't go through the descriptive results here, I'll just show you a graph. The red line is circumcised men. As you see, as their false beliefs increase, so does their circumcision satisfaction. The opposite is true. The actual trend is not statistically significant for non-circumcised participants, but it was significant, the slope analysis for the circumcised participants. We had an incidental finding was that gay men were less satisfied with being circumcised. This is a difference of about half a point on a short scale, which is rather significant. This is consistent with prior research. Jennifer Bosio and her colleagues who we met earlier doing the penile sensitivity studies found that men who have sex with men indicated a strong preference toward intact penises for all sexual activities assessed and held more positive beliefs about intact penises. The implication of this is that parents who authorize a neonatal circumcision may be differentially affecting their son's future sexual enjoyment depending on his sexual orientation, which is not something that can be known in infancy. So, a seemingly obvious suggestion is that you should just defer the surgery until a time at which the person can decide whether that's something he'd like to do to his own genital organ. Some advantages associated with this are that the organ has now reached its full size. There's no guesswork in terms of where to cut, and so you don't have the problem of potentially removing too much tissue, as we discussed earlier. The patient can select exactly how much tissue and of what kind he'd like to have removed. There's a frenulum, which is the sensitive tissue that connects the foreskin to the penis. Sometimes that's removed, sometimes not. If you'd like to preserve it, you could tell that to the surgeon. Similarly, there are different, as it were, styles of circumcision, very high and tight or low and loose. Depending on your preferences, you could actually say, I'd like it this way versus that way. An infant has no ability to participate in that kind of decision making. So the patient generally can perform a personal risk-benefit analysis, assigning weights to the benefits and risks in light of their own preferences and values rather than the sort of dictates of a distant committee deciding on behalf of everyone else. The patient can request effective anesthesia. So infants, general anesthesia is contraindicated in infants. It's too risky, and so a less effective form of pain control has to be used. And of course, the infant can't demand more pain control other than by sort of inarticulate crying, whereas an adult can manage their own pain needs as necessary. Also, the neurodevelopmental period for setting pain thresholds has closed, so there's some work suggesting that early exposure to painful experiences can have a number of downstream adverse consequences for neurodevelopment, but as with many other aspects of circumcision, these are grossly understudied, and therefore the risks that are associated with neurodevelopmental outcomes is currently unknown. And finally, it would be voluntary. I'll close with just an objection. Some people say, well, if you defer the surgery, the problem is that the risks associated with it increase, so it must be done early when the risks are less. This is a common refrain. I'll say why I don't think this is a very convincing response. First of all, just to accept, for the sake of argument, it may be true, but of course any number of operations may be less risky in infancy. You could remove an infant's earlobes. It might be less risky in infancy, I don't know. Neonatal labiaplasty might be less risky than labiaplasty later in life, but no one would consider this as constituting an argument in favor of early labiaplasty for girls, even though some may very well go on to choose it. Ritual tooth extraction, scarification, these sorts of things may very well be less risky in infancy. There are no data on this, but if it were, I don't think anyone would consider them good arguments for performing the surgery early. In other words, the prior question is ethical. If we determine that it's not ethical to perform an early surgery, then debates about the relative risk profile in infancy versus later become moot. But second, the claim that it is indeed less risky in infancy has serious problems. This claim is based upon retrospective comparisons of non-concurrent studies using dissimilar populations, dissimilar methods and criteria for identifying complications, and so they fail to adequately control for the method used, the device, the skill of the practitioner, the environment, and so on. So this claim, which is oft repeated, why it must be done early because you're running out of other reasons, is based on a very poor data analysis. Finally, even proponents of circumcision, those who are most dedicated to it on medical or other grounds, say that the absolute risk of serious, hard-to-resolve complications, and here they mean additional surgical complications, they don't, of course, consider the loss of the foreskin itself as a harm, is what they describe as low at both ages. So this is the difference between relative and absolute risk. You might have a relative risk reduction by doing it in infancy, but if the overall absolute risk is low enough, this is morally irrelevant because a low risk divided by any amount is still a low risk. So even on the proponent's view, I would argue this is not a very compelling argument. And the loss of the foreskin, however, is a 100% risk. And so as I've said, because your attitudes about the meaning, physical and symbolic, of the loss of the foreskin itself may diverge greatly depending upon your attitudes, it's this risk that we should pay most attention to. Thank you.